Usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Oh, absolutely. Like it's a math equation or something.
Right. It feels like engineering. You break your arm, the x-ray shows that jagged white line, the doctor points to it, puts a cast on it, and you just wait 6 weeks and move on with your life.
Yeah, a very neat, predictable timeline.
Exactly. We like things to be visible. We want them neatly categorized with a definitive end date for the treatment.
But stepping into the world of craniofacial anomalies, I mean, that shatters that expectation completely.
It really does.
Suddenly, that metaphorical X-ray machine doesn't give you a simple binary of, broken or fixed. The diagnostic landscape is incredibly complex.
Because the timeline isn't measured in weeks anymore, is it?
Not at all. It is measured in decades. It requires an entirely different framework for thinking about healthcare, honestly, both for the patient and the system that's delivering it.
Which brings us directly to our mission for you today. We are looking at a really fascinating stack of orthodontic and craniofacial texts covering the management of cleft lip and palate.
Or CLP, as it's often referred to in the literature.
Right, CLP. But the absolute centerpiece of our discussion today, like the main catalyst for everything we're going to explore, is a highly influential 1998 Clinical Standards Advisory Group study.
The CSAG paper.
Yeah, the CSAG paper authored by Sandy and his colleagues. This single paper completely revolutionized a nationwide healthcare system.
It really was a watershed moment.
Okay, let's unpack this, because before we can understand the sheer magnitude of what Sandy and his team actually uncovered, we have to look at the mechanical and anatomical realities of what managing a cleft lip and palate actually entails.
Yeah, to give you a sense of the scale here, cleft lip and palate is the most common birth defect of the craniofacial region. Globally, it occurs in about 1 in 700 live births.
Which is a lot more common than people might think.
It is, but the sources highlight some really fascinating demographic variations. The incidence isn't uniform at all.
Right, I saw that. It's highest in Asian populations, I think.
Exactly. Coming in at about 1 in 500 live births. Then it drops to roughly 1 in 700 to 1,000 in Caucasian populations. And it actually appears lowest in African populations at about 1 in 2,500.
That's a massive variance. And the sources also pointed out a truly bizarre anatomical quirk that I was stuck on.
Oh, the directional thing.
Yes. Unilateral clefts, meaning a cleft that only affects one side of the upper lip and jaw, they are twice as likely to occur on the left side of the face as on the right.
It's wild, isn't it?
It is. I spent a long time trying to wrap my head around why a birth defect would have a directional preference like that.
Well, the answer lies deep in embryonic fetal development. It's specifically regarding the cardiovascular system.
Okay, so it has to do with the heart.
Basically, yeah. Very early on in utero, the right side of the fetal head receives a slightly more robust blood supply.
Why the right side?
This happens because the aortic arch, which is the main vessel routing blood from the heart, develops on the right side.
Oh, wow.
Right. So that minute difference in early vascularization, I mean, just a tiny bit more blood flow, seems to provide just enough developmental support and tissue oxygenation to make the right side of the face fuse more successfully.
So it literally just makes clefting less likely over there because there's better blood flow.
Exactly.
Just a slight difference in blood flow in the womb dictates the entire anatomical structure of a child's face. That is incredible.
It's fascinating biology.
But then once that child is born, the treatment pathway they face is just incredibly demanding.
Oh, it's grueling.
It actually starts before the child is even born, doesn't it?
It does. If the cleft is caught on a prenatal 20-week ultrasound, the parents undergo intense specialized counseling to prepare them.
Because the minute that baby is born, you bypass the normal newborn routines and enter an immediate logistical crisis, which is feeding.
Right. The physics of nursing, or, taking a standard baby bottle, they rely entirely on vacuum pressure.
Suction.
Exactly. A baby seals their lips and drops their tongue to create negative pressure, drawing the milk out. But an infant with a cleft palate has a physical opening between the oral cavity and the nasal cavity.
So they can't create a vacuum at all. Air just rushes in from the nose.
Precisely. They cannot generate suction. So a rigid plastic baby bottle is completely useless to them.
So what do?
The very first intervention, usually within 48 hours of birth, is bringing in a specialist cleft nurse.
And they teach the parents how to use those specially designed bottles, right?
Yeah, the squeezable plastic bottles. The parents literally have to manually squeeze the milk into the baby's mouth.
That sounds so stressful.
It is. And they have to time their compressions perfectly with the infant's natural swallowing and breathing rhythm.
Oh, so the baby doesn't aspirate the milk into their lungs.
Right, because the risk of choking is so high.
And that's just the hurdle of week 1. When you look at the timeline in these texts, it's a relentless cascade of interventions.
It never really stops.
At 3 to 6 months of age, the infant goes under general anesthesia for primary lip repair surgery.
Which is major surgery for a baby that small.
Then, around 9 to 12 months, they go back under for palate repair. And closing the anatomy early creates its own set of future problems, doesn't it?
It's the ultimate double-edged sword. The human body heals by forming scar tissue.
Naturally.
So when a surgeon repairs the palate in 9 months, they inevitably leave scar tissue along the roof of the mouth.
Okay, and that causes issues later.
Huge issues. As the child grows over the next 10 years, that non-elastic scar tissue acts like an anchor. It functionally tethers the upper jaw, restricting its forward and downward growth.
Wow. So the very surgery that fixes the palate early on is the same thing that causes severe underbites later in life.
It's an unavoidable biological trade-off. You have to close the palate for speech and feeding, but you know it's going to restrict growth. And because of that restricted growth and the missing bone in the cleft area, by the time the child is 7 to 10 years old, they face another major hurdle.
The secondary alveolar bone grafting.
Yes.
I read up on the mechanics of this, and it is intense.
It's not a minor procedure.
The adult canine teeth are trying to erupt, but they basically have no bone to anchor into. So the surgeons have to harvest cancellous bone like the spongy marrow.
Usually by cutting into the child's iliac crest at the hip.
Right, they literally take that hip bone, open up the child's gums, pack the harvested bone into the cleft defect, and sew the gum tissue tightly over it.
It's a massive trauma to the body.
It's a 2-decade-long relay race. I mean, you have this massive multidisciplinary team acting like a complex orchestra.
That's a great way to put it.
You've got audiologists checking for fluid in the ears, speech therapists working on articulation, orthodontists trying to widen a restricted jaw, and plastic surgeons manipulating bone and soft tissue.
And every single specialist has to play perfectly in sync.
Yeah.
Your orchestra analogy captures the precise dependency of this timeline. If the initial surgeon leaves excessive scar tissue at 6 months, the orthodontist is basically fighting a losing battle trying to align the jaw a decade later.
Right, the dominoes just fall.
Yeah. Or if the palate isn't closed with enough muscular tension at 9 months, the speech therapist cannot teach the child to produce normal consonant sounds at age 5.
Because the structure just isn't there.
Every single intervention cascades into the next, permanently altering the canvas for the next specialist.
So when a treatment requires 20 years of perfect sequential timing, the hospital system managing that care has to be absolutely flawless.
It has to be airtight.
But in the late 1990s, rumblings started echoing through the European and British medical communities that the UK system was completely missing the mark.
Yeah, things were not going well.
And this is what triggered Sandy and his team to audit the hard data, which culminated in that 1998 Clinical Standards Advisory Group report.
The famous CSAG audit.
Right. They looked at 2 specific cohorts of children born with unilateral cleft lip and palate across the UK. It was 5-year-olds and 12-year-olds.
And the structural reality of the UK healthcare system they uncovered was just startling.
It was a mess.
They found 57 active cleft teams operating across the country, employing a total of 75 different surgeons.
Now, on paper, to a politician or a hospital administrator, that probably looked fantastic.
Oh, they probably bragged about it.
Right. It looks like incredible regional coverage. You have a cleft team in nearly every major town. A family doesn't have to travel far to get their baby surgery.
It highly prioritizes convenience.
Yes, convenience. But here's where it gets really interesting. The CSAG report revealed the fatal flaw of that widespread coverage.
And it was a massive flaw.
Because the patient population was spread so thinly across those 57 different centers, the majority of those 75 surgeons were performing less than 1 unilateral cleft lip and palate case per year.
Less than 1 per year. Let that sink in.
It's unbelievable.
The surgical volume was virtually non-existent for most of them.
Imagine taking your car to a mechanic who only looks at a transmission once every 14 months.
I wouldn't do it.
Right. They might have the manual, but they don't have the feel for it. Now imagine that transmission is the delicate soft tissue, airway, and facial structure of a 6-month-old infant.
It's terrifying when you frame it like that.
You cannot expect a high-level outcome from a system built on occasional practice.
You really can't. Medicine, and particularly complex reconstructive surgery, is fundamentally a repetitions game.
It's about muscle memory.
Exactly. It relies on deep muscle memory, instantaneous pattern recognition, and seamless team cohesion. Manipulating the levator muscles in a tiny infant's palate requires microscopic precision.
And if you only do it once a year.
When a surgical team only sees that specific anatomy once a year, they simply never build the critical expertise required to optimize the tissue.
And the clinical outcomes discovered by Sandy and the team reflected that exact reality, didn't they?
They did. The numbers in the 1998 audit are stark.
Let's look at how the teeth and jaws were developing. Our sources note the study used standardized measurements, specifically the Gosselin yardstick and the 5-year-old's index.
Right, and for context, the Gosselin yardstick isn't a literal physical ruler.
Oh.
It's a clinical grading system. Assessors take dental models, like plaster casts made of the children's teeth, and they rank the relationship between the upper and lower jaws on a scale from 1 to 5.
With 1 being good.
Yes, a score of 1 or 2 is excellent. A score of 4 or 5 means the upper jaw is so severely restricted that the child will likely need highly invasive orthognathic surgery later in life.
Which is where they actually break the jaw.
Yes, where the facial bones are physically cut and moved forward.
And the CSAG audit found that an astonishing 37% to 39% of the children in both the 5-year-old and 12-year-old cohorts fell into those poor or very poor categories.
Almost 40%.
The report also noted that 70% of the 12-year-olds had a skeletal class 3 malocclusion.
Yeah, the underbite.
Right, that means the maxilla, the upper jaw, failed to grow forward properly, trapping the top teeth behind the bottom teeth in a severe underbite. 70%.
And the surgical failures extended beyond just jaw growth. We discussed the secondary alveolar bone grafting earlier. You know, the surgery where bone is taken from the hip and packed into the gums around age 8 to 10.
The really painful one.
Yeah. Well, the CSAG audit revealed that 42% of those bone grafts were severely defective or had failed entirely.
Wait, 42%? Taking a step back, why is that specific surgery failing so frequently for low-volume surgeons?
It all comes down to tissue management and vascularization. For a bone graft to survive, it needs an immediate, rich blood supply.
Okay.
So the surgeon has to stretch the surrounding gum tissue over the new bone and stitch it completely watertight.
No gaps allowed.
None. If the surgeon isn't highly experienced, they might create too much tension on the stitches.
Because the tissue is already scarred from previous surgeries.
Exactly. So a single stitch pops. Just a millimeter of the wound opens, and saliva containing oral bacteria seeps into the graft site.
Oh, no.
The blood supply is compromised, and the transplanted bone simply necrotizes. It dies.
So nearly half of these kids endured a major bone harvesting surgery, went through the brutal hip recovery, only for the graft to die and fail.
Which is devastating.
Meaning they either had to do the surgery all over again or face losing their permanent adult teeth in the cleft area.
Right.
And the system was also failing at the most basic level of pediatric dentistry. The audit found that 40% of the 5-year-olds had active dental caries, or cavities.
It shows that the decentralized system was fundamentally broken at every single level, from elite plastic surgery down to routine oral hygiene education.
Sandy and his co-authors lay all of this out in 1998. They essentially hold up a mirror to the UK medical establishment and prove that their convenient, highly localized model is actively causing harm.
Which was a bold move.
The prescription they proposed was politically radioactive. They recommended shutting down the vast majority of local cleft clinics and centralizing care.
Collapsing those 57 scattered units down to just 8 to 15 high-volume centers.
If we connect this to the bigger picture, the entire philosophy shifts from geographical convenience to concentrated expertise.
Right, and to reinforce this shift, our sources cite another crucial paper from that era, which was Williams et al., published in 1999.
What did they find?
Well, Williams provided compelling evidence that patients treated by high-volume surgeons had vastly superior speech outcomes.
Oh, right. Speech is such a massive part of this.
It is arguably the most functional outcome for the child's social integration. When we speak, our soft palate acts as a valve.
Okay.
It rises to close off the nasal cavity against the back of the throat so we can build pressure to pronounce consonants like P, B, and T.
Without air leaking out the nose.
Exactly. This is called velopharyngeal competence. If a surgeon only operates once a year, they might just, close the hole in the palate.
Just stitch it shut.
Yeah. But a surgeon who does this 30 times a year knows exactly how to dissect out the abnormally attached palate muscles and reorient them into a functional sling.
We aren't just patching a hole.
Right. They don't just close the anatomy. They construct a working valve.
The most remarkable part of this story is that the UK healthcare system actually listened to the data.
They really did.
They executed a massive, highly disruptive health policy shift. They took those 57 autonomous units and condensed them into just 11 managed clinical networks, operating out of 17 primary operative sites.
And that centralization accomplished way more than just funneling patients to fewer surgeons.
What else did it do?
It allowed the national health system to impose strict quality controls. They mandated minimum data sets. Every single center now had to record and report the same clinical metrics using the same standardized indices like that Gosselin yardstick.
Oh, I see. This removed the ability of localized clinics to hide poor outcomes behind inconsistent paperwork.
Exactly.
It created an environment of forced transparency. They also heavily restricted training, didn't they?
They did. A surgeon could only receive specialized cleft training if they were embedded in one of these approved high-volume centers.
They essentially forced the members of the orchestra to practice in the same room every single day under the same conductor.
Exactly right.
So they tear down the old system, they endure the political headache of closing local clinics, and they force all the kids to travel to these elite centers. The big question is, did this massive reorganization actually move the needle for the patients?
To answer that empirically, the UK government commissioned a direct follow-up study.
Okay.
It was called the Cleft Care UK Study, or CCUK, published by Persanen and colleagues in 2015.
So almost 20 years later.
Right. The entire methodology was designed to replicate the 1998 CSAG audit, looking at the new generation of children raised entirely within this centralized high-volume system.
So what does this all mean? When they looked at the data from the centralized system, what actually changed?
Clinically, the improvements were profound. Yeah. Dental-alveolar outcomes, so the alignment of the jaws measured by those plaster casts, showed a radical turnaround.
Okay, because under the old system, we saw failure rates approaching 40%.
Right. But under the new centralized system, over 50% of the 5-year-old patients were scoring in the top 2 categories of the index.
Wow, so the high-volume surgeons were managing the tissue better, leaving less scar tissue, and allowing the kids' jaws to grow naturally.
Exactly. Furthermore, facial appearance showed slight but consistent improvements across the board.
That's huge.
And validating the earlier findings by Williams from '99, speech outcomes were definitively better than in the CSAG era.
Because they were building better functional valves for these children.
Consistently, yes.
However, the texts do make sure to point out that centralization wasn't a magic bullet for every single symptom. There were several stubborn clinical problems that remained entirely untouched by the surgical overhaul.
True. Hearing outcomes, for example, did not improve.
Why not?
Well, a cleft palate inherently disrupts the levator veli palatini muscle, which is responsible for opening and closing the eustachian tubes in the ear.
Oh, so that leads to chronic fluid buildup and hearing loss.
Yes. Even the most elite palatal surgery couldn't fully resolve that underlying anatomical vulnerability.
And the cavity rates also didn't budge, right?
Unfortunately, no. The incidence of dental caries in the 5-year-olds remained just as high in 2015 as it was in 1998.
Because having a world-class plastic surgeon doesn't change the day-to-day realities of brushing an infant's teeth around sensitive surgical sites and misaligned gums at home.
Exactly. Which actually brings us to the most counterintuitive and revealing finding in the entire CCUK follow-up study.
I know what you're going to say.
What's fascinating here is the data concerning parental satisfaction.
Yes.
Consider the clinical picture. The children's jaw growth, their facial appearance, the success rates of their bone grafts, their ability to articulate clearly.
All of these objective, physical, disease-centric metrics improved radically. The surgeries are working, the bone grafts aren't failing at a 42% clip anymore, the kids can speak without air escaping their noses.
And yet, when Person's team surveyed the parents in 2015, they found absolutely no difference in overall parental satisfaction compared to the old failing system from 1998.
I honestly read that section of the source material 3 times to make sure I wasn't misunderstanding it.
It's baffling at first glance.
Wait, the surgery's working better, the speech is better. Why aren't the parents happier? How can the medical outcomes improve so dramatically while the people receiving the care remain exactly as satisfied or dissatisfied as before?
It really illustrates the profound difference between a clinical metric and the lived human experience.
Because of the travel.
Mostly, yes. Centralization improved the surgery, but it vastly increased the logistical burden on the family.
Oh,
Think about it. In 1998, parents might have been receiving suboptimal surgical care, but they drove 15 minutes down the road to get it.
right.
In 2015, to access that elite high-volume center, families were now traveling 2 or 3 hours each way.
They paying for gas, taking multiple days off work, paying for hotels, trying to find childcare for their other kids back at home.
Exactly. The financial and emotional tax of just getting to the hospital skyrocketed.
It's a massive geographic penalty.
It is. And on top of that logistical burden, you have the psychological phenomenon of shifting baselines.
What do you mean?
As healthcare systems improve, patient and parent expectations rise proportionally.
Oh, I see.
In 1998, given the poor overall outcomes across the board, a parent might have been relieved simply to have the visible hole in the lip closed. They might have accepted a severe underbite or a speech impediment as just an inevitable part of the condition.
But by 2015, the new baseline is near perfection.
Right. So if a child requires a few years of braces to fix a minor crowding issue, or maybe needs a few months of speech therapy for a slight lisp, the parents might feel deep disappointment and frustration.
Even though their child's outcome is comparatively a modern medical marvel.
Exactly. The clinical team is looking at the jaw measurements and celebrating a victory. But the parents are exhausted from a 4-hour round trip and worried about a minor lisp.
It perfectly demonstrates that treating a complex condition involves far more than just executing a flawless surgery. The family still has to navigate a grueling 2-decade reality.
It's an incredible realization.
You can fix the x-ray, you can force the orchestra to play perfectly in tune, but the parents are still the ones driving the tour bus for 20 years.
That is so true.
So, for you listening right now, why does this deep dive into a 1998 cleft palate audit matter? I think the CSAG paper by Sandy and his team is an absolute masterclass in having the courage to look at your own hard data without flinching.
Definitely.
The UK medical establishment could have buried those numbers to protect the egos of those 75 local surgeons. Instead, they recognized that a decentralized system, while popular and convenient, was structurally incapable of delivering excellence.
They faced the music.
They forced a painful, politically unpopular reorganization. And because they follow the data, thousands of kids today can speak clearly and smile with confidence.
It's a testament to the reality that good intentions and convenient access aren't enough when dealing with complex medicine. You need repetition, you need volume, and you need the humility to let objective data dictate the structure of care.
Absolutely.
Which actually raises an important question to think about long after we wrap up here. If centralizing cleft care radically improved physical outcomes simply by forcing doctors to become high-volume experts, how many other highly specialized medical or surgical procedures in your own local healthcare system are currently suffering right now simply because the care is spread too thin across too many hospitals?